And here I am again, and there are you, still in that same seat. Kidney stones, nephrolithiasis. Now, the first part of it about etiology, wow, you know, even my mother knows that stones are made out of calcium oxalate. Even my mother knows that stones are made out of calcium oxalate, so there's two different parts to the question. Etiology, calcium oxalate, but then what's the significance of this? Well, let's see. Anything that increases your amount of calcium in the GI tract is going to form stones. Stone him! Anything that decreases your oxalate is also going to form stones. Stone him! Why? Because if there's no oxalate in the gut to bind that calcium, where's the oxalate? Okay, so it's going to have oxalates. Oxalates might form more calcium too. Oxalates. Well, the other thing is this thing, magnesium aluminum phosphate. Magnesium aluminum phosphate is a person who has infections. Struvite. Klebsiella proteus, struvite. Now, what's unique about uric acid stones? What's different about uric acid? Don't tell me that's because they're from uric acid. I know that. Uric acid stones are radiolucent. What's different? Radiolucent. They don't show up. Indinavir. Well, those uric acid stones are radiolucent. They don't show up. Not on an X-ray anyway. See this stuff, Indinavir? Indinavir is a protease HIV medication. And the significance about Indinavir is that Indinavir causes 4% of people with Indinavir, 4% of those patients are going to form a stones. 4% of those patients are going to form stones. So let's see, that's the next thing. Well, increased hypercalcium in the urine. I got a lot of calcium in my urine. Sure, a lot of it in vitamin D, but you know, more common than vitamin D junkies, more common than sarcoidosis and granulomatous diseases, more common than all of those, more common than hyperparathyroidism, is simply people who increase the urine in calcium. Increased urinary calcium excretors. I don't have hypercalcemia, I don't have hyperparathyroidism or myeloma or cancer. I just increase my excretion of calcium. That's actually the most common reason. So all these things here, a lot of vitamin D, granulomatous, sarcoid, this is really saying, hey man, what causes hypercalcemia? By the way, what is the single most common cause of hypercalcemia that there is? Guy shows up, he's asymptomatic and has a high calcium. Guy shows up, he's asymptomatic and he has a high calcium. What's the most common cause? Hyperparathyroidism. Not sarcoid, not cancer, not granulomatous diseases, not vitamin D intoxication or myeloma. Good old-fashioned hyperparathyroidism. Separate from that, you see this thing here? Idiopathic renal hypercalciuria. It means, I don't know why, but I got calcium in my urine. Now, increased oxalates happen because fat binds with calcium. When you have free fatty acids and you have either sodium or a calcium, you know what that's called? It's called soap. It's called soap. When it's binding a fat with sodium, that's regular soap. When it's with calcium, it's also known as soft soap. Not as harsh, with calcium. Soap, man. So what happens is you see this fat malabsorption? It's binding the calcium. And when you're binding the calcium, you're increasing the oxalates being absorbed. Now, oxalate can be a good thing, and citrate too, to bind calcium. But if the calcium is being otherwise bound up with free fatty acids, fat malabsorption, that means you have increased oxalate absorption, and the increased oxalate is resulting in increased oxalate in the urine. Now, you see these crystals? Starry, starry night, paint your crystals blue and gray. See those crystals there? Well, if you look closely enough, you'll see that they look a little like an envelope. Now, when you see crystals that are shaped like an envelope, what are those called? They're called envelope-shaped crystals. Brrr. Now, envelope-shaped crystals from hyperoxaluria can be from fat malabsorption. The fat binds the calcium. The fat binds the calcium, the oxalate goes into the urine. You should also look for someone who tries to commit suicide. Suicide. You ready? A patient is brought to the emergency room after having been found with a suicide attempt. The urinalysis shows oxalate crystals. What's the most likely etiology? Ethylene glycol. Ethylene glycol. Flip it. Ready? A man has been trying to commit suicide in his garage. He's drinking antifreeze wine coolers. He's having mojitos made with Prestone antifreeze. He's having an antifreeze mojito, and he comes to the emergency room intoxicated. What is the best initial test? Urinalysis. Urinalysis. You ready? They could say a guy comes with suicide and he's drinking antifreeze. What's test first? Urinalysis for oxalate crystals. They could invert it and say a guy comes with oxalate crystals in his urine. What had caused it? Ethylene glycol. They take the same question, flip it back and forth. Okay. Remember also, suicide with that also going to give an increased anion gap metabolic acidosis. Treat with ethylene glycol or fomepizole. Ethanol or fomepizole, ethanol or fomepizole. Next one. Citrate. Do you know in a unit of Paxil, see this word citrate? Ready? Look at this one. Oh, we got a guy who had a motor vehicle accident. He had 10 units of blood, fast. 10 units of packed red cells, fast. 10 units of blood, fast. He said 10 units of red blood, fast. 10 units of red blood cells passed, and now he has a seizure. Why? Why? Low calcium. Why? Why? Because citrate bound up the calcium and caused a seizure. Because citrate bound up the calcium and caused a seizure. Citrate binds calcium. That's good in a unit of Pax cells. It's a natural anticoagulant. Keeps the blood anticoagulated. That's bad if you get it all bound up. You can cause a seizure. Low citrate causes you to have increased calcium absorption. Calcium citrate. So if you have low citrate, and what happens? Sick people have low citrate. Increased calcium absorption. Now here's the other thing here. Most stones, calcium-containing stones, do they form in a basic environment or an acid environment? In a basic environment or an acid environment? The answer is they form in a basic environment. Except uric acid stones. Uric acid stones have two excepts. One is uric acid stones form in an acid. Can you get me again? Which one forms an acid? Is it the uric acid stones or the oxide? Oh, the uric acid stone forms in an acid urine. Oh, I never thought of it like that. Oh, you're so smart. Uric acid stones form in an acid environment, and they don't have calcium in them, or you would be able to see them on an X-ray. Now, cysteine is basically one small blip. It's people who overproduce cysteine. It's a genetic disorder. That's it. Now, Proteus infections. Proteus infections increase the pH. Proteus infections increase the pH. When you increase the pH with a Proteus infection, you get struvite stones. When you increase the pH with a Proteus infection, you get struvite stones. When you increase the pH with a Proteus infection, you get struvite stones. Very straightforward. Calcium, magnesium oxalate. Now, let's look at our presentation of a kidney stone. Oh, look at all these things. So let's do something. How do we get a question out of this, you know? That's part of the issue. Look at this. Oh, you got blah, 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 blah. Well, how do we extract a question out of that? Constant flank pain radiating to the groin. All right, hematuria. Wow, stones, strictures, tumors, cancers. Look at all these diagnostic tests. 1, 2, wow, 6 diagnostic tests. Man, I don't even know what to do. I don't even know what to do. I don't know what to do with all the information. That's a lot of information, but let's juice a question out of that. Anybody can give you information. We're in an information age. Well, let's see. We got a 42-year-old guy who comes to the emergency department. He's got terrible back pain radiating to his groin, and he's got hematuria. Terrible back pain radiating to his groin. Wow, renal colic. You know, people have kidney stones, and people given birth say that the kidney stone was more painful than the birth. Excruciating, sudden, severe, overwhelming, like you've been hit in the back with a baseball bat. He's incapacitated with pain. Look at these diagnostic tests. We got an x-ray, sonogram, strain the urine, calcium levels, CT scan. What is the single next best step? What would you do first? What's the most appropriate action at this time? ¿Qué tú quieres ahora, papito? Что видите сейчас? Что видите меня? Моя подруга. Oh? What do you want to do? Do you want to do an x-ray? Do you want to do a CT? Do you want to do a sono? Do you want to do a spiral CT? You want to give pain meds. You want to give pain medications. The first thing to do here is pain medications. The first thing to do is pain medications. Look, I'm all for straining the urine. I'm all for the spiral CT. If it's an office-based case, and the person is stable, chronic, I would use sonogram, ultrasound or sono. In the emergency department, the first test might be an x-ray, if x-ray is in the choice. CT scan, spiral CT, is your answer to which of the following is the best or the most accurate. First, I would do an x-ray if they give you a choice, although frankly, x-ray misses 10%. But the first thing to do when someone comes in with renal colic, doctor, is relieve suffering. Relieve suffering. Guy comes in with excruciating, overwhelming pain. Cut the guy a break. Give me a pain med. When is pyelogram? See this? IVP, intravenous pyelogram. When is that the answer? Never. Intravenous pyelogram is a dead old test. It should be Grisiel fulvin, the CT myelogram in the Department of Medical Archaeology at the Smithsonian Institute. Dead archaeologic. It's gone the way of the Brontosaurus and the 8-track tape player. Pain medications is first. In the office, sonogram and diagnostically. CT, spiral CT is an excellent test. You don't even need contrast. And IVP is always wrong. Now, let's see. This is an x-ray of a big, huge stone. Look at that big honker stone. Well, here's the thing about stones. If they're very small, in other words, if you have a stone that was under 1/2 centimeter, you could wait. The people who are small, you can wait. Now, when they become larger, between 1/2 centimeter and 2 centimeters, it's too big to wait. As a matter of fact, anything above 4 to 5 millimeters will never pass even into the ureter. These people should get managed with lithotripsy. If it's really big, above 2 or 3 centimeters, surgical removal. And what does surgical removal? Surgical removal means putting this lithotripter inside the kidney and blowing it up and irrigating it out. So what's our point here with nephrolithiasis? The single most important question is, what do you do for overwhelming pain with renal colic? Pain medications. Ketorolac, which is Toradol. Ketorolac and pain meds. Really small? Wait. A little bit bigger? Lithotripsy. Bigger than that? Surgery and percutaneous removal. Put that lithotripter in the kidney and boom! Blow it up, irrigate it out. Calcium oxalate stones are number 1. Yes, it's true, hyperparathyroidism, sarcoid, and vitamin D junkies and cancer and immobility cause high calcium. But the most common cause of a high calcium is simply over-excreting calcium in the urine.